Afternoon, everyone. We'll just wait for some more people to trickle in before we get started. And I'll give it another 15 seconds, then we'll get started because I feel like we're going to have another really great presentation today and hopefully a lot of good discussion. So I'm just going to start. I think most people who join our webinars now know me by now, either through the webinars or through all the emails you get from me from PCMCH. I'm Leslie Tarasoff. I'm a program manager at the Provincial Council for Maternal and Child Health, and I support a number of pediatric-focused programs, networks, initiatives, including the Paediatric Diabetes Network. And my colleague Smita is here joining us as well, and she's a program coordinator supporting PDN and some other pediatric programs at PCMCH. So glad you could join us for this kind of last webinar, I'm going to say, of the summer, even though it's not officially summer, but we're going to take a break and then we'll regroup in the fall, and we already have some exciting webinars already booked for the fall. So before handing it over to our speaker, I would like to provide an acknowledgement of the land and First Peoples. I would like to begin by acknowledging my sincere gratitude for the opportunity to work and live on this beautiful land that has been occupied by First Nations since the beginning of time. This land on which PCMCH operates is the traditional territory of the Haudenosaunee, Wendat, and Anishinaabe peoples. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13, with the Mississaugas of the Credit. Toronto is now home to Indigenous peoples from across Turtle Island. PCMCH recognizes that Indigenous practices of health and well-being have been in place in this territory since the beginning of time and are maintained to this day. We are committed to honoring and improving our knowledge on these practices. We recognize the harms and mistakes of the past, and we take meaningful steps toward reconciliation by building and improving relationships with First Nations, Inuit, and Métis people. Just a little bit of housekeeping before we get into the presentation. So you will be able to use the Q&A function on Zoom or raise your hand. For some reason, our administrative settings for Zoom, we can't use the chat, but please put your questions, comments in the Q&A. And then when you raise your hand, we will give you permission and unmute you when you have a question. Hopefully no one can hear my dog barking in the background. And just to introduce our topic and our presenter today, so we're very lucky to have Dr. Jessica Kichler back with us this month to do part 2, building on her great presentation from last month. And today her presentation will focus on practical approaches to addressing fear of hypo/hyperglycemia in diabetes clinic, and with a specific focus on some case studies. So I'm going to stop sharing and hand it over to Jessica.
Excellent. Thank you very much. I appreciate the opportunity to be here again and to build on last month's conversation. So let me share. One second. Of course, when I closed, when we were practicing and I closed it, I closed the whole thing. There we go. It's back. Bear with me one second. All right. Can I get a thumbs up that you can see in here? Okay, great. And again, I just have closed captioning turned on my PowerPoint, so that's where the text is floating around the bottom just to aid in listening, but I don't promise that it's always accurate. I'm taking a minute to disclose my conflicts of interest and my relationships with the grants that I've received, different speakers bureau and honoraria that I've been on, and different advisory boards I've been on over time. And I have no patents or other commercial disclosures. So what we're going to do today is do three things. I'm going to review, I know a number of you were either at the last talk or you've watched it remotely, but I will spend a couple of slides just reorienting everyone to the framework of the psychosocial impact of diabetes in general. And then we're going to hone in a little bit on fear around diabetes, including fear of hypos as well as fear of hypers, as just one of the examples in which we could use some of our motivational interviewing strategies to help patients manage the psychosocial aspects. We could have different talks on depression and distress and all kinds of other ones, but I'm going to focus today primarily on fears and anxieties. And then hopefully you will learn some more practical approaches on how to manage these types of fears within a diabetes clinic visit and as part of routine diabetes care. So again, for those of you who attended before, this is a little bit of a review. I won't spend too much time, but just to reorient everyone. So giving credit to Dr. Michael Vallis for this slide, who's given me permission to use it. We talk about the psychosocial impact of diabetes on individuals. And as you all well know, different people have different types of psychosocial reactions to being diagnosed or having diabetes, or diabetes progressing over time or at different developmental stages. And so those who perceive diabetes and its management as maybe a threat to their health and well-being, that can lead to feelings of anxiety. For those who perceive diabetes as representing a loss in their life, maybe a loss of their former healthy self or a loss of freedom or independence, then that can lead to feelings of sadness. And those who perceive diabetes as unfair, it's unfair that it happened to them, why me? That can often lead to feelings of anger. So different people have different reactions, and they may have some combination of that over time. But what I'm going to focus in today is this perception of threat, where individuals who see diabetes as a threat, and so they start to develop some anxiety symptoms. And we'll talk a little bit more about, I'm not talking about a clinical diagnosis of sort of generalized anxiety disorder or OCD or that sort of thing, where it's a mental health diagnosis, but these are psychosocial concerns. So they're very specific to diabetes, but there is a lot of anxiety symptoms in there. And so we're going to focus in on that. And just as a reminder, hopefully everyone in this room already knows this well, but I ground this talk in two ways. One, to help develop interventions and strategies to help support the glycemic and self-management goals of all of our patients with type 1 diabetes. But secondly, and sort of probably more importantly for me, is to more holistically care for the individuals with diabetes on their psychosocial adaptation, independent of its impact on their glycemic stability or instability, and really helping people live and thrive with diabetes more holistically. So having this focus on psychosocial concerns has the twofold impact. And then just as a quick reminder, I also have a theoretical grounding, and motivational interviewing has a theoretical grounding, oftentimes seen in self-determination theory. And this is the idea that if these three psychological needs are met in human beings, then human beings have a natural propensity to grow and gain fulfillment and do things with their lives. And so self-determination theory really is a motivation theory that if these three psychological needs are met, individuals often are more motivated to engage in their diabetes care and have improvements in their well-being and other outcomes. So just as a quick reminder, if we, in our relationships with our patients and the people we work with diabetes, if we can build a sense of connectedness, feel that sense of belonging, that they are in the right place and they have attachment to either people on their medical team or people in their social network around diabetes, if we can foster a sense of competence, that we have a belief that they can gain mastery over these tasks, that we want to empower them to feel like they have that self-efficacy, or that belief that if they do these tasks or these self-management activities, that they can manage and sort of feel successful and feel a sense of mastery over diabetes. We also want to foster a sense of autonomy, again, developmentally appropriate autonomy, but autonomy, feeling, giving everyone that sense of it's their agency or their control over what they want to work on, how they want to work on it, what they want their life to diabetes to be like. So giving them as much of their choice as possible. So high quality diabetes care incorporates these three things. And so we're going to talk a little bit more about how we do that. And just as another reminder, we talked about miscarried helping last time, and then I ended with effective helping. This goes for all of us. We're all in the helping profession. We all chose to be helpers. We by nature are helpers, and we really want to be helpful and supportive. But we'll have to think about how we choose to be helpful. Help is not necessarily helpful or high quality if we do it in a way that inadvertently or paradoxically makes someone feel shamed and blamed and discouraged and unmotivated. It doesn't matter if our intent is to help, if we do it in a way that is actually making things worse, not better. So the whole focus of last talk and this talk is to have all of us who want to be helpful have that drive to be helpful. How can we be helpful? How can we ask others what we can do? How do we actively listen, respond with potential suggestions? We have expertise, we know a lot, but how we disseminate that, how we talk about it, how we engage matters, so that the person with diabetes feels empowered, heard, and understood. Then they're motivated and they see their team members as part of this larger team that believes in them and has a sense of can give them a sense of competence, so that the person with diabetes takes a more active role in their own diabetes care decisions, feels comfortable communicating needs and setbacks. We don't want the patient to come in and say, everything's all good. I don't feel comfortable or willing to share with you the things that aren't going well because I feel shame and blame. So we want to do effective helping, and we're going to talk a little bit about ways to do that. So we're going to do that in looking at fears and anxieties around diabetes. So I have a quick poll here. Again, it's 1, 2, 3, or 4 and daily. How often do you manage fears and anxieties during clinic visits on a daily? 2 to 3 times per week, 1 time per week, or less than once per week. And again, I'm not holding you to this. You don't have to bean count it, just a general gut check of how often you feel like you're addressing fears and anxieties. Okay. And okay, it looks about 39% are doing it on a daily basis. Excellent. With another 39 doing it 2 to 3 times per week, 1 time per week, and then less than 1 time per week. So this is a group that is already very keyed into anxieties and fears, which you'll see later in the talk. We talk a little bit about how few people, how few it's happening, how what's the word I'm trying to look about, is how rare it is for diabetes clinics to be talking about anxiety on a regular basis. So I love that you are already doing that, and so hopefully this will help just continue to build your repertoire. Okay, so I want to talk about 2 cases, but again, this is a case study sort of presentation. So if there's other cases, I'll go through a couple of them, but I'll leave time at the end. So if there's other cases or other specific situations, again, without breaking personal health information or anything, you are welcome to at the end put them in the question and answer, and I'll help sort of brainstorm and problem solve as well. So I wanted to start on both ends of the spectrum, right? We have the fear of hypos, And then I'm going to do the second case of the fear of hypers, right? So this is a compilation of many different patients. This is not one patient that's being described here, even though I'm presenting them as one patient. And so I've just put together a brief summary of this patient just so you can relate to, you know, some of the background information. So it's an older adolescent with type 1 for 10 years, very high achieving, sports and school, uses a pump with control IQ to help with glucose management, and is very thoughtful and analytical about cause and effect, always aware of insulin on board, considers all foods, and not just counting carbs, it's also looking at the amount of protein they're eating, the amount of fat that they're eating, concerned about downward sensor arrows, even no matter the value of the blood glucose levels. If there's an arrow, that's very sort of hyper attended to. He's aware that his fear of hypos is affecting his actions and his glucose values, but feels very overwhelmed when he feels like he's going low. He wants in target range numbers, and he is aware of risk complications, but feels that the low blood sugar will negatively impact his ability to stay on top of things with school and sports. So some of the behaviors he engages in is altering pump settings, reduces or omits carb inputs, puts himself in activity mode almost all the time, suspends his pump, you know the drill. Takes a low treatment for any blood glucose under 11, sets lots of alarms and alerts for falling, for lows, has a max bolus unit in his head that he doesn't like to give doses more than 3 units at a time. So therefore he eats very low grams of carbs at meals and snacks because he wants to minimize the need for a quote unquote large bolus of more than 3 units. So, you know, he's actually quite good at staying at 11, if you want to say that. So, you know, he takes a low treatment for any blood glucose levels at 11. He is successful, if you will, at staying at that 11 level. So despite wanting it lower, not feeling safe at a lower level, so he treats it if he's really in anything in that 9 or 10 or below range. And you can see his time in range profile in terms of being in the high to very high, the most of the time with some in target ranges, and then never low or very low. So he's actually quite successful. If we wanted blood glucose levels to stay right around 11, he's got this to a science. It's just that it's higher than we want. He's an individual who would be showing a fear of hypoglycemia. So we're talking about more of an extreme fear of hypoglycemia. We'll talk in a couple slides about how fear is not necessarily a bad thing, but having this fear of hypoglycemia to such an extreme level really can impact. And before we get into that, I want to talk about there's many different ways of having a fear of hypoglycemia. It doesn't just have to be, I have a fear of low across the board. It could be that you have a patient who has fear of lows during the daytime because they don't want to go low at school or be embarrassed in front of their peers. Or it might be a fear of nighttime only. They feel like, hey, when I'm awake and I'm alert, I can handle it. But as soon as nighttime and I'm asleep, I'm worried what will happen while I'm asleep. It could be in social settings that they don't want to go low in front of other people, or they could have a fear of hypoglycemia while they're alone and there's no one there to help them. So there's lots of different types of places. So it's really important that when you have someone who's expressing some fears, that you get into a little bit of the details and the nuances of where they're having these fears of lows. Is it that the caregiver has a fear of lows and that's being sort of modeled and role modeled to the child or the adolescent, or is it the patient themselves who has the fear? Was there a medical trauma? Was there a severe low? It doesn't always have to be that there's been a severe low, but was there a severe low that then created some sort of a traumatic response? And so they're trying to avoid that at all costs. There's also different components to fear of hypoglycemia. So on Bill Polanski's HABS, which is the Hypoglycemic Attitudes and Behaviors Scale, which is cited below, there's 3 subscales, and that's the more traditional hypoglycemia-related anxiety, where you worry about a low, being in public with a low, and so you stay near home. Then there's avoidance, where you keep your blood glucose levels higher, you treat carbs even without a blood glucose check, and you go based on how you're feeling versus what the numbers say. Or it could be a confidence, that's another subscale, where you don't feel like you keep yourself high because you don't feel confident in your ability to keep yourself safe from serious problems, or that you can catch a low when you're alone or driving. So these are some nuanced ways to think about hypoglycemia and the fear of it, and the context and the components. It's important to remember that although this is not a DSM diagnostic criteria mental health disorder, the same physiology is coming into play here around anxiety and fear. And so when all of us have fears and anxiety, we go into fight and flight. There are a number of physiological changes, including liver releases extra glucose, cortisol is released, so you're more insulin resistant, digestion slows. And so all of these things are happening that are creating higher blood glucose levels as well when you're in fight and flight. So really thinking about how your patient with fear of hypoglycemia is really sitting in this fight and flight state of being, rather being in the parasympathetic, the rest and digest, calm state, where we've calculated their dosing and their basal rates and all of those things. So it can feel like there's a little bit more insulin resistance because they're in that constant heightened state of fight and flight. And like I mentioned before, fear is not a bad thing. Fear is actually a wonderful thing. It is a good thing. I don't want to send the message here that having any sort of fear or apprehension or awareness of a low is what we want. So this Yerkes-Dodson law for anxiety and sort of arousal around the fight and flight, if the fear is too low, right, and we don't have a sort of a healthy appreciation for lows, then people run low all the time, and that can be very dangerous and scary. But what we're talking about with fear of hypoglycemia is sort of going over the top of that hill and being at the high level, where performance is again at suboptimal levels. So that's where they're doing everything that I talked about in that case study, where you're not giving boluses, or you're treating with extra carbs when it's not needed. So we really are trying to get our patients back to that middle level, that sort of optimal arousal, where there's optimal performance, not too low, not too high, but sort of just right in terms of a healthy appreciation, that they won't, if they're having a low, they won't get behind the wheel of a car. But at the same time, if they're stable, that they don't have a fear of driving, and so then they can't get themselves to school in the morning or whatever it is. So that middle ground is kind of what we're looking for. Because what can happen with lows is this idea of the maintenance of fear. And so this is fear in general, but it just happens to be focused in on diabetes. So this is where it doesn't become a diagnosis of generalized anxiety disorder if it's just compartmentalized to just diabetes or just a fear of low. And so what happens here is there's a stressful event. There's people that have a biological vulnerability to moving into fight and flight very quickly and very easily. And they have some sort of an alarm reaction, right? So your heart rate starts going up, your breathing's faster. All of these things happen when there's a stressful event. Maybe it's that downward arrow. And then they start having catastrophic thoughts. I'm going to die. I'm going to pass out. I'm dizzy. And then they have a behavior that comes from that, either running away from it, sort of metaphorically, in terms of, giving themselves that carbohydrates, or suspending the insulin, or overriding a bolus. And then they have this hypersurveillance and this anticipatory anxiety, even when there's not a low. Every little shift in the arrows, they're watching and they're paying attention, which increases anxiety because now you're hyper aroused for that. It makes it more likely for the alarm reaction, more catastrophic thoughts, more avoidance, and you can be off to the races. And this fear can sort of take over. Then that number, maybe you were comfortable at an 8, and now you're only comfortable at a 9, and now it's a 10, and now it's an 11. And so that can get exacerbate over time. Another way that anxiety is maintained is this idea of when patients engage in that avoidance activity around, suspending a bolus or giving extra carbs or what have you. They have that anxiety going up. Oh, I see that arrow. I'm nervous. I'm going low. Maybe it's a downward arrow at 12, but they have that buildup of anxiety, and then boom, I'm going to do something to make myself feel less anxiety. So I'm going to suspend that bolus. I'm going to give those extra carbs. And then the anxiety goes down immediately. And so they have that relief from anxiety and that sense of worry, but that doesn't last long. There's another buildup. And then the next time it's an even higher anxiety response. And then you have to engage in more avoidance or more escaping to get the relief from the anxiety. But we know that those avoidance behaviors that give them the relief from the anxiety are also the behaviors that drive up blood glucose levels. So they're in this competition with each other. And so then this pattern can go on and on and on, where they're sort of stuck in this, I got the anxiety buildup and then I get the relief. So one therapeutic approach is to have repetition and duration of exposing them to their feared response. So whether this was you were having a fear response of spiders or low blood sugars or heights or whatever, this is the treatment is called exposure and response prevention therapy. Again, I'm not wanting you all to become therapists, but I want you to understand the sort of behavioral change mechanism so that we can think about how we can help with increasing the exposure slowly and carefully. There is a flooding approach, but we're going with slowly and carefully in exposure, where there's going to be a repetition of their feared situation and a longer period of time in which they have their feared situation happening. Now, I'm not saying we're going to run them low and make them tolerate a low. I'm just saying we're going to run them more and more closer to the in target range and have them tolerate that. So we'll talk a little bit more about how we do that. But what happens there is you'll have an initial anxiety burst. Well, they will get very anxious. And as long as you can outlast that anxiety burst, the human body can't stay in that super high fight and flight for very long. If they keep having it, and then their exposure, then their fight and flight will drop while the exposure to the in target blood glucose is still there. And so then there's a natural decrease, and then they stop pairing the fight and flight with the trigger of like a downward arrow or something like that. So this is called exposure and response prevention, and you're retraining your body physiologically how to have responses to the stimuli, the feared stimuli. So what does this look like in diabetes? So I have here sort of 3 categories. So there's the diabetes care, education, and support. So everyone on this call who does this, right? All the social workers, nurses, physicians, nurse practitioners, everyone, dietitians, everyone here can think about within their scope of practice how diabetes education and support can play a role. So the multidisciplinary team can look at insulin dosing titrations. And so what I'm saying here is you can, think about what is their sort of optimal dosing, and then what is the dosing titration that would maybe we'll use our case example, would get him to an 11, okay, or maybe a 10. But what would give it where he was practicing giving the full dose, but you are actually titrating it so that it's actually a little bit less than what you would want him eventually to be on. Because what's happening is he's overriding the system so much. If he can start getting into the practice of not overriding and giving what he's supposed to be giving, and you on the back end change that dose to match kind of where his fear is, and then you slowly titrate and increase that dose so that as he's practicing giving the full doses and not overriding. And so a lot of times I'm making the goal is less about what the blood glucose level is and more about how many overrides there have been, how many suspensions there's been, or how many times he's given a carbohydrate dose for himself. And so we're watching the sort of output so that if you can match where he is and then slowly work his insulin, and so you slowly crank it back up to where his dose should be. That's what I mean by insulin dosing titrations. You could do carb strategies before physical activity. All of the dietitians in the room and everyone can talk about how to add the protein and when and how high to rank yourself and how to slowly base your carb intake during physical activity based on the intensity and the duration and all of that. You can raise the target blood glucose level temporarily. Like I was saying before, you can sort of match that his goal. If he's really good at getting himself at 11, we can say, hey, we want you to be at 10. I'm not saying from like a CPG guidelines, I know this is not what, but if you're going to match that and say, hey, we're going to dose you to a 10, and if you can say to 10, then we can move that down to a 9, then we can move that, down to an 8 and on. So that's another strategy. Exploring technology, although I have an asterisk here. This case study, this person was already on all the technology. For those who aren't on the technology, there are small to moderate effects for adults with type 1 diabetes that adding technology, adding a CGM for someone that has a fear of hypoglycemia is beneficial. However, that's not very conclusive. And as the authors talk about in this article, there's a lot more need for more support because it can be a mixed bag. Some people can have fear of hypoglycemia, and then that CGM just is another tool to be hyper vigilant and hyper arousal on every little beep and every this. So you just have to play that one by ear and just know that it's not a panacea, that technology will fix all hypoglycemia fears. But it has this small to moderate effects. So less is known for kids. But I've had some patients where technology was very helpful, sort of gave them peace of mind, and others, it just made them more hypervigilant. So just take that with a grain of salt. And obviously to communicate collaboratively to get them to support and problem solve, because what's happening is a lot of times that fear of anxiety, fear of hypoglycemia is driving that anxiety. And then if they feel like you're just going to crank up the dose to compensate for them suspending and overriding and giving all of these things, then their dose actually might be too high if they were to actually give it. I've had that happen too, where we have people who were not dosing, and then their actual insulin ratios and everything was slowly moving up, so that if they actually gave what was prescribed, they would go low because everyone was trying to compensate. So having that open communication about what do we actually need and how do we get there. Then there's exposure and response prevention. Again, you don't have to do the full therapy or become a therapist in this, but there are some great tools that you can do. And I'll show you on the next slide. You can compare side by side symptoms, fight and flight symptoms and hypoglycemia symptoms. And it's an interesting activity to do with your patients. You can also help your patients tolerate that anxiety burst and distress and see if they can go, 1 minute, 2 minutes without engaging in those checking behaviors when they are feeling pretty confident that it's an anxiety symptom and not a fight and not a hypoglycemia, because those symptoms are so similar that it's really hard to tell the difference. And so if you can really help your patients think about, is this anxiety or is this the physiological sensations of going low? And then that can be helpful for them to tolerate some of that anxiety burst, or they've treated a low and now they have to wait the 15 minutes and really tolerate waiting before stacking all those carbs on top of each other. There's also a lot of cognitive behavioral strategies that have empirical evidence. I talked at the last time about the different therapies that have grade A evidence behind them. So as you saw in that maintenance of fear, there's a lot around their thinking, their behaviors and avoidance, their emotions and their physical sensations. And so a lot of times this is where referring to the social work team, the mental health team can really help them get a sense of how do they do some of those thought stopping and changing those behaviors as well. I want to give an example of what I've done before with other patients as I've had them look at hypoglycemia and fight and flight or anxious symptoms. I had them write down in 2 columns, what symptoms do you have for your lows and what symptoms do you have for your fight and flight? And if they were in both categories, we crossed them out. So you can see for this example, sweating, irritability, shakiness, hard to concentrate, fast heart rate. Oh, but the hypoglycemia, weak in the knees, and this anxious symptom was heavy breathing. That didn't come with hypo. And so everyone's different. But then what I did with my clients that we did this with is I had them not pay attention to their sweating, their irritability, their shakiness, they're hard to concentrate. But hey, am I breathing heavy or am I feeling weak in the knees? To really start to see if they could get a better grasp over I'm in fight and flight or I'm in hypoglycemia. And you know, we always can check and things like that, but I was having some kids check nonstop. And so we were trying to have them sort of, or they wouldn't wait to check and they'd just go ahead and start to eat the carbs. So wait and see what's happening and then do a CGM check or a blood glucose check or that sort of thing. So again, this is another way to have people sort of look at their symptoms and then do exposure and response prevention where you're exposing them to having that heavy breathing. We know you're anxious. We know that this is fight and flight, and we want you to tolerate that for a little bit longer before we immediately go to doing your avoidance so that we can tolerate that and know that they're safe and all of that. And then if they're feeling weak in the knees, go ahead and check, but then it's the exposure and response. Don't give 30 grams of carbs, you know, give your 15 and 15 and move and wait and do those kinds of things to sort of minimize the stacking and things like that. So these are some examples of things I've done in working with fear of hypos. So we'll get to a poll question here. On a scale of 1 to 10, how confident do you feel about problem solving and collaborating with your patients who have hypoglycemia? All right, good. It looks like we have a lot of people in that sort of 6 and higher range. So that's excellent. So hopefully these give you some tools and strategies and some articles and things to keep working on, some assessment tools too. Okay, so now I want to switch to the other end of the spectrum. We have a case review of a fear of hyperglycemia. And so we don't talk about this as much, but you can see this happening. So this is, again, not any one specific patient, but this is a collaboration of a lot of different patients, but I'm assuming most of us have seen this scenario. So a 10-year-old active girl with diabetes for 4 years, uses a pump and CGM. Mom works hard to manage the diabetes, follows closely, initiates boluses or texts child to bolus if blood glucose is anywhere around 8 to 9, worries about keeping them as low as possible. The goal is to never be over 8, reacts quickly to hypers, and you can see the time in range. You know, 78% is time in range, right? But then you can see that we've got 10 and 2, 12% sort of in those low and severely low range. So then, you know, there might be some nights with prolonged time in range, time below range. You know, when you ask the mom, they say, oh, they're inaccurate. The CGM, you know, she was sleeping on her elbow, on her arm, or what have you, and bolusing a whole lot, just really kind of the other end of the spectrum of overriding, setting alarms and alerts, but anytime anything's over 9, they'd like to do looping, and mom eagerly shares her ideas. And the teams maybe approached her trying to say, oh, we have some fear of hypos, or how often she's going. And mom states that she's really just wanting her daughter to have a full and normal life and is really trying to prevent the complications. And the child is active and seems happy and not overly concerned with lows either. Um, so this is more of a caregiver, can have some fear of hyperglycemia. So there is a scale out there called the hyperglycemia avoidance scale, or it's hyperglycemia aversiveness or avoidance. So there's not a lot of literature out there, and it's mostly adult literature, but I think we can extrapolate to this mom here. So in general, a fear, quote unquote, of hyperglycemia in adults with type 1 is around 16.4%. And so those are the people who have an excessive concern about elevated glucose levels and the potential complications. This is not about people who have hypoglycemia unawareness, where they have hypoglycemia unawareness, so they're very fearful of just going low out of nowhere and not being aware of it, so they prefer hyper to hypo. So the articles are very clear to separate those people out, but really people who don't have hypoglycemia awareness, they don't go low any more than anyone else with diabetes. But the hypos make them feel, these are people where the hypos make them feel safe, and protected from the long-term complications. So they have basically a lower hypoglycemia action point. So where we would suggest, okay, it's time to treat, it's time to give some carbs, they're saying, no, 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 I'm good there, I'm good there. And so their levels of time in range really is often quite good, because they're often running in that middle range. Sometimes they're at the very high range, but they're sort of really good at keeping themselves in that in target range, because they're so fearful of ever crossing over into a higher blood glucose level. And they don't always report higher levels of diabetes distress. So these are the people who are very on it, and they can come to clinic as seemingly very put together and in charge and engaged, but not allowing for sort of the occasional or the upper level, and then running themselves low as a consequence. And so, like I said, there's a scale that can measure sort of how much individuals are avoiding hyperglycemia. And we don't ever want to make hyperglycemia sort of all bad, that this is part of it and it's going to happen, and that we don't want to do hypo at the expense either. So this is where I want to pull in some of those skills. This is where I, as working with individuals who have this sort of avoidance of hypers, and creating too many lows. I want to use some of those motivational interviewing skills that we talked about last time. And so just as a quick reminder, there's three core skills, three guiding skills around asking, active listening, and informing. Again, asking the open-ended questions where the patient does most of the talking, letting the patient you're talking with think out loud. And so I've added a slide on some really good open-ended starters. I remember when I was first learning motivational interviewing and doing this, I would write these on like a little post-it note and have them on with me in my binder that I was taking into rooms, just as a little reminder, because there's some deceptive open-ended starters where do you, will you, can you, is it, did you, are you. Those are close-ended. Those require one-word answers or kind of close down the conversation, versus tell me about, to what extent, what else, help me understand, how did you, what, if any, are really good sort of open-ended questions that you can use to explore with different patients, especially around fear of hypers, or really anything. When it comes to active listening, as a reminder, we had the ORs, the open-ended, the affirmations, reflections, and summaries. And the affirmations, reflections, and summaries are showing that you want to understand what they're saying. You're double checking what you think you've heard, and it opens the door for people to keep talking. So you've got the that sort of 3-to-1 or 1-to-3 ratio, where you do one open-ended question and then do about 2 or 3 affirmations, reflections, and summaries, where an affirmation would be, thank you for sharing this. You can give a compliment. You're clearly very committed to your daughter. Empathy, not many people would have managed it like you did. Gratitude, you have great ideas. Gestures, the hand movements, the nodding your head, the thumbs up, those things that you're really affirming for them, that you hear them and you understand them. You can give reflections, and these are powerful. This is I think the crux of what I find the most helpful about motivational interviewing is when reflections are holding up that mirror and sort of reflecting back to that person what they just said, so that then they can process what they said and then react to their own selves. In this sort of verbal processing. So you can do a simple reflection like a content, repeat what you're saying is, what I heard you say is, blah blah blah. You could go to the next level and do a feeling, acknowledge what you're feeling. It feels as though every time you see a high, that makes you feel worried about the future for your daughter, or you feel overwhelmed by highs, so that you're getting sort of beneath the surface a little bit. Maybe you're hypothesizing by giving meaning, and you say, you're saying that for you, hypers mean that she's going to have complications. And so you're sort of taking what they said to you at the surface level and sort of giving that higher level meaning to it. Doing a double-sided reflection, I always joke I should have like really strong biceps, because I'm always doing the hand gesture with this, where you highlight ambivalence by saying, on the one hand, you don't want your daughter to have the lows, and on the other hand, highs also feel like they're going to cause complications. So you're feeling between a rock and a hard place, between both ends of the spectrum, right? So you're putting out there sort of both rationales and both reasonings, so that you're talking a little bit with them, that I hear both sides of the equation, and that you're not just trying to push your agenda, but that you're really sort of meeting them where they are, and then continuing to have discussions about how do we find that middle ground where we're minimizing lows and highs together. There are times where you can side with the negative, where you demonstrate that side that they may not be ready for change. If you're really finding that you're kind of hitting a wall over and over, it just seems like you're not sure about making that dosing change yet today. And you can just reflect that. What would it take for us to make you feel more confident, right? So that you're not then just overriding them with their power, but you're reflecting to them, this is what I'm hearing you say, and how do we shift that over time? And using summarizing at the very end of your interaction. So again, I was just practicing motivational interviewing earlier this morning for a mentor, a teen mentor, no, very young adult, and then they have mentees for a project in Winnipeg. And we were doing a practice motivational interviewing, and we gave ourselves it's about 5 to 7 minutes. And then at the end, making sure you're summarizing. So to summarize, I'm hearing this, this, and this, once you've sort of decided what you all are going to work on, or what's the goal, or what's the change, or the dosing change, so that they have a good sense of what you all talked about and what sort of where you all landed. And then ending with an invitation. Is there anything else I should know, or anything else that we haven't covered? So that's the S part of ORS. And then in this last part, and again, this is third for a reason, because a lot of times we as helpers, we move informing to the front and then do our asking and our active listening at the back. But informing is at the end, because that is the priority. It doesn't mean we can't inform. It doesn't mean we can't give advice. It doesn't mean we can't share our expertise and our knowledge. But we need to make sure we're doing it in a way that's not lecturing, not coming across as should. Like I said, don't should on your patients. And we have to resist the fixing reflex. For those of you who've had any motivational interviewing training before, you might have heard resist the writing reflex. It's now changed to fixing reflex. And that's where you invalidate their ambivalence. So by trying to fix it, and they say, well, I think it's a pressure low because of the CGM. You say, well, that doesn't actually happen all that much, and this is for 2 to 4 hours. I'm sure she rolled over, right? That coming back and trying to fix what they said or write it is very invalidating. So you've got to resist that, and instead use a technique like the ask, offer, ask, where you ask for permission, you offer some information or advice, and then you ask how they've perceived it. So the ask, offer, ask is you elicit what they already know about the situation. So you might say, what do you already know about the effects of hypoglycemia? What concerns, if any, do you have about hypo? Use your or skills based on what the mom would say to demonstrate your active listening. Allow them to express that ambivalence. And then offer, getting permission. Can I share with you some information I have about hypoglycemia? If yes, then you can offer, well, this is what we think, and this is how we can dose for it and change it, whatever your expertise is on that. But then it's like a sandwich. You've also got to close it by asking again, what do you think about what I said? What do you want to do with that information? So the ask is the sandwich, the offer is the meat or the middle of the sandwich, and then the ask is the other end. And making sure you have that ask, offer, ask, so that you're not just giving the offer and then walking away and not really seeing how it landed, how is it perceived, how is it interpreted, so that you know what their thoughts were and how likely they were to sort of take it up and to use it. So I use the ask, offer, ask all the time, especially when you have someone who is so committed, like this mom with this girl with frequent lows and the fear of hypers. You don't want to go in sort of trying to fix it and make it better, because she's just going to double down and then not share with you the times that there are lows or what have you. So using these ask, offer, ask really helps get to the ambivalence and the worries that they have, and then you can see whether you can find ways to unhook some of those concerns that they may have, or find different ways of managing it. Okay. And so just in order to leave a little bit of time at the end, last time I had a different slide with some different books. I put some new ones on, some bright spots and landmines. Raising Teens with Adam Brown is a phenomenal speaker if you haven't seen him. He's great. Raising Teens with Diabetes is a classic and old one, but the author Moira is a mom with, well, now a young adult with type 1. And Think Like a Pancreas. You may have all seen these before, but these are some of my favorites on my bookshelf. I also want to do, again, I know I did my disclosure slide, but I will promote, because I get no financial benefit from it. But Breakthrough T1D Canada has diabetes training for healthcare providers on mental health training, as well as mental health providers to get training on diabetes. So we sort of have both directions. There's also a diabetes and mental health conference coming up in May of 2026, and I'm on the planning committee for that. So please go to that. Please register for it. There's a continuing ed track, and then there's a person with lived experience track. And then ISPAD, International Society for Pediatric Adolescent Diabetes Conference, is in Montreal this year. So anyone able and willing to go to Montreal, it's so rare that it's back in North America. And I'm also on the planning committee for that. So, but I am doing a shameless plug. I get no financial benefit from that, but there'll be a lot of different mental health speakers there, and I'm excited to see that. So I will end there and stop sharing, and then look to the Q&A and get reactions, thoughts, other questions.
Thanks so much, Jessica. I feel like there was so much information packed in that in your talk, and I think we'll also share the links to the various resources and books after the talk today. So if anyone has any questions, comments, you can put them using the Q&A. Oh, I see one just as just some feedback. Great thought. Thanks for sharing some real life examples and strategies to help us with our clients. If anyone has any questions, comments, use the Q&A or put your hand up and we'll figure out technology and how to unmute you. I'll just give it a few seconds. Okay, there's a question from Jocelyn. I'll just read it out loud for everyone. Are you aware of any training on motivational interviewing specifically for diabetes professional this information was so helpful and would be beneficial for our entire team. And we can definitely, for those who weren't able to join today, we can share the recording because we always record our webinars and rounds.
Yes, this is such an interesting question. So, there's a book on motivational interviewing for diabetes, but it's mostly type 2. So if you are someone that has works a lot with individuals with type 2, there's a book. It's fairly old, but we can get it and I can send it along as well. Um, it's okay. And there's a book on that, but it is so built around type 2. When it comes to type 1, there really isn't. And in fact, when I'm working on a motivational interviewing intervention, like I just talked about in Winnipeg, um, and we have been searching, and we wanted all of our mentors to get just like motivational interviewing training, and we had to do it generally. And even the facilitator, she didn't know the first thing about diabetes, but then I sat in, and then I sort of like adapted it. And so all the projects I've been involved with, it's been those of us who've like learned how to adapt it, and maybe this is my like $1 million idea, right? Jocelyn, you and I can pair up and we can create it. But I don't want to dissuade you from taking the general MI courses. They have those free ones online, and motivational interviewing's got a lot of resources for doing little extra ones, but none of them are really diabetes specific. But you, as the diabetes expert, can see it and sort of adapt it as well. And that's really just what I've done. Is it's very, very applicable to diabetes. And so there is one book, and I'm happy to share that, but it's more of a type 2 book.
Oh, I just see a comment from Tiffany saying PsychWire has an excellent motivational interviewing course for healthcare providers, although it is not diabetes specific.
Yeah. Yeah. And then that's a great, thanks, Tiffany. So the one I love, I think I put it on the last one. There is, the Spirit of Motivational Interviewing, for healthcare providers. There's a book on it too. Again, healthcare providers. So I'll put that one on. It's probably even better than the one that's type 2, so type 2 specific. But motivational interviewing for healthcare providers is also a book, as well. Thanks, Tiffany, for that. That prompted that other one.
Yeah, I'm curious if there might be learnings from other, maybe not diabetes, but like obesity or other chronic health conditions that children and youth have, if there's maybe that might be somewhere to look for resources that are not specific to diabetes, but maybe a little less general.
Yep.
Yeah.
Absolutely. Absolutely, for sure. And yeah, Razy, all the slides have already been submitted, so they'll be shared.
Yeah, we'll share the slides, and if anyone, we know not everyone can always join the webinar, so if anyone, we can share the link to the recording, and you can share with your other team members. So if there's no other questions, I'm just going to share my screen again. And just to say thank you so much, everyone, for joining us over your lunch hour. I know how busy all of you are, so it's really great that we've been having such great attendance at our webinars and rounds, and we will be sending out. So if you registered via Zoom, tomorrow you'll get an email with the evaluation survey link, but also send a reminder about that next week. And just to let you know that, again, we'll be sort of taking a break over the summer, but we already have some webinars scheduled for the fall, and are looking for, PDEP staff. If you're willing to volunteer to lead rounds in the fall, please reach out. And again, the rounds don't have to be very formal. You don't have to prepare slides. If you just want to talk about some specific clients or complex cases or questions, or talk about different tools that you use or what's been effective, we can be really open to what those rounds look like. So I think we really just want to be in a place where people feel comfortable and open to, share resources across the network, get advice from each other, because I think everyone's doing really great work, but sometimes we're not always sharing what we're doing and learning from one another. So I think these rounds and webinars could serve as really great capacity building opportunities. And again, feel free to reach out to myself or Smita if you're interested in this or have ideas for future webinars in terms of topics or speakers. They don't have to be based in Ontario. We've had a really good luck reaching out to speakers, and everyone's been really eager and willing to present. So again, thank you for joining us for the webinars this past few months. And again, thank you to Jessica for leading two of them. I think there was a lot of really great, rich information that many of us can learn from. And again, we'll share the link to the recording and also the slides and resources in the coming week. So thank you all so much for joining. And Smita has put the evaluation survey link in the chat. Right. Thank you all so much and have a good rest of your day and rest of spring before we hit into summer and people get busy and take vacation. Thanks so much. Bye.
Thank you, everyone. Bye-bye.